genesis of the National AIDS Control Program and the National AIDS Control Organization. Okay. So in India, initially the National AIDS Control Program, before the program was there, so initially it began as a project funded by the international agencies, where began with serosurveillance, where so looking for HIV in diverse population groups, specifically among high-risk population groups, among sex workers, among migrant populations, bridge populations, like high-risk populations like female sex workers, male having sex with males, and then some bridge populations like truck drivers, migrant workers. Among those, mainly these serosurveillance activities were initially happening. The National AIDS Control Program got launched in 1992, and since then it has evolved over several stages. And currently we are in the stage 5 or phase 5 of the National AIDS Control Program. So phase 1 of this National AIDS Control Program was on 1992 to 1999, which focused mainly on awareness generation and blood safety. So during this time, the blood transfusion rules, what testing need to be done. So a mandate of testing of HIV in all blood transfusion, all of these were set up. This was during the phase 1, 1992 to 1999. Phase 2 was the next part from 2000 to 2007, which launched direct interventions across prevention, detect, treatment continuum. So this is when treatment of HIV started being available under the national program. The antiretroviral therapy was available for free to HIV infected patients under the national program. So for treatment, detection, and prevention to be available across the country, we needed capacity building of states. So state aid control societies were set up across the country during this phase. 2007 to 2000 is the area of scale up. So here the program is trying to move on from the state level to district to have its presence in every district. This is a period where ART was free and was given to every individual who had a CD4 count of less than 500. So that was the cutoff that we were using previously, that only people with a substantially low CD4 count would be treated with antiretroviral therapy. And finally, you had this phase 4, which was from 2012 to 2017, which was the period of consolidation and enhanced government finding. At the end of this phase, the objectives of the phase 4 were not completed. So phase 4 was extended for another 5 years, and it went on till 2021. And it is from 2021 to 2026 that we are having the phase 5 of the National AIDS Control Program. So moving on, what were initially the national AIDS response, if we look from 1885 to 1991, before the beginning of the National AIDS Control Program, what was happening was basically serosurveillance. So targeting groups and having serosurveillance, constitution of a national committee, focus on blood screening and awareness generation. So blood product screening was beginning, and there was a plan for identified vulnerable areas. So there were some specific districts, specific parts of the country having a very high prevalence of HIV in southern states and in the northeast. And the program was being started in those areas to try and address the burden of HIV. Going ahead in NACP phase 1, so this is when the National AIDS Control Program was established. So under that, we had the National AIDS Control Bureau being set up, the National AIDS Control Organization, and State AIDS Control Societies, formulation of that. And there was implementation of large-scale awareness generation campaigns among people that this is a disease which is a lifelong disease, and it cannot be cured once you get the disease. And at that time, treatment was also not available very well. So it was all about prevention, prevention, and prevention through screening of blood and through safe sexual practices. Okay. And the beginning of licensing of blood banks and banning of professional donors. So people who were professionally donating blood, that was abolished to prevent people trying to hide infections in order to gain money out of donating blood. Okay, so the banning of professional donation was a significant step that was taken in this phase to prevent the transmission of this disease. Okay, and the government realized that it was not possible for the government to reach all of these difficult to reach and high risk populations. the provision for collaboration with non-governmental organizations or community-based organizations for preventive interventions among high-risk groups was also taken. So many a times in community medicine, you're asked about public-private partnership. You have to realize that the AIDS control program is one of the cardinal programs of the government of India, where the scope of public-private partnership was brought in specifically to try and reach this high-risk group and high-risk populations. Okay, along with expansion of the surveillance networks. Next, come to phase two. Phase two is when the program is already up and running. So here there are the focus is now moving on to the blood screening and blood was the thing that was happening before. Now we are trying to diagnose the burden of the disease across the country. So there is establishment of the facilities of VCTs. So previously these were known as voluntary counseling and testing centers, named as VCTs. And PPTCT is prevention of parent to child transmission of HIV. Okay, so you know that since it is a sexually transmitted disease, a disease that is transmitted through body fluids. So if the mother is pregnant and the mother is having HIV, there is a high chance, almost 20 to 45% chance of the mother transmitting that HIV onto the child. So prevention of transmission of this HIV from the mother to child was very important, especially in a situation where antiretroviral therapy was not properly available. Okay. Along with that, there was introduction of antiretroviral therapy. So antiretroviral therapy at that time was very expensive and it was completely out of reach of the common people. So introduction of antiretroviral therapy and establishment of antiretroviral therapy centers from where people could go and get these drugs for free and remain under treatment with regular supply of drugs. Okay. There was a national constitution of a national parliamentarian forum and a national council on AIDS, an adoption of national AIDS prevention and control policy and the national blood policy. Till date, it is the national blood policy that dictates all of the process of blood donation, testing of blood, cross-matching, and ensuring that in no way do we transmit infections by the way of blood transfusion. So whenever we have a blood sample, the blood sample is tested. It is tested for HIV, hepatitis B, hepatitis C, malaria, and syphilis. These five tests, these are mandated, which must be done to prevent the transmission of these diseases by way of blood transfusion. Okay. So national blood policy was formulated in this phase in NACP phase 2 to make transfusion of blood safe. Next in NACP phase 3, which was from 2007 to 2012. So here there was scale up of the facilities pan India with development of district based facilities. Okay. And in order to strengthen the parent to child transmission of HIV, this was the phase where mandatory HIV counseling and testing services were included as part of antenatal care services. So NACP was in collaboration with the RMNCH program that was underway. HIV counseling and testing services were integrated with pregnant women. Pregnant women surveillance of HIV among pregnant women is also done to classify districts as high risk or low risk. Okay, so depending on what is the prevalence of HIV among pregnant women, districts are classified as high risk or risk. Okay, so HIV counseling and testing services, which is now routinely done for all pregnant women, it was started at that time. Okay. Other than that, next coming to the NACP phase 4. In the NACP phase 4, the most important thing was the launch of the National HIV/AIDS toll-free helpline, which is 197. 1097, it is the toll-free helpline till date, and a dual elimination of vertical transmission of HIV and syphilis. Okay, so we realized that these are two diseases that have a high co-occurrence and that have a high rate of vertical transmission from the parent to the child. And you know that syphilis congenital transmission can cause various problems in the child. Okay. So dual elimination strategy. Now also when you're referring a person comes from syndromic management of STI, you're referring to ICTC. There is dual testing for VDRL for syphilis and rapid testing for HIV. So the adoption of HIV syphilis joint elimination was done during this phase. Also, certain high risk settings where in prisons where there is a lot of male having sex with males and other kind of problems there, high risk settings. So NACP interventions were launched there. Strategic expansion of the HIV screening through ICTCs and CBSs. The CD4 cutoff level for treatment initiation was shifted to 500 cells per millimeter cube. Okay. And AIDS is the only disease in our country for which we have a dedicated law. Okay. So the HIV AIDS Prevention and Control Bill was put forth during the NACP phase 4. Okay. In the continuation phase, so NACP did not achieve all of the things that it set out to achieve in the phase 4 from 2012 to 2017. So it continued as the NACP phase 4 extension from 2007 till 2021. So during this period, it was originally approved up to 2020 and then extended to 2021. The main cardinal thing is the passing of the HIV/AIDS Prevention and Control Act. The act was enforced in September 2018. The key provision is to ensure equal rights to treatment and to prohibit discrimination against affected HIV-infected individuals. We'll come in more detail to this act. So the key clinical initiatives during the NACP phase 4 was the test and treat policy of April 2027, which says that it abolished the previous guideline of keeping this to 500 cells per millimeter cube. This was abolished. So at now what started is the moment a person is diagnosed with HIV, irrespective of the CD4 count, the treatment with highly active antiretroviral therapy known as HAART, highly active antiretroviral therapy. It's a three-drug regimen. A highly active antiretroviral therapy is started immediately upon diagnosis of HIV. So this was the main one of the very good initiatives that began that has gone a long way in controlling the burden of the disease. So the moment someone is diagnosed, they're put on treatment, irrespective of their CD4 count. It does not matter whether they have symptoms. It does not matter what is their CD4 count. They need to be started on treatment immediately on diagnosis. So that is the test and treat policy. Next, a lot of people who were lost to follow up due to uh, inadequate availability of medications or due to side effects of the previous medications. So there was a dedicated drive to bring back people living with HIV under the aegis of the program and to put them again on highly active antiretroviral therapy. So this was known as the Mission Sampark, which wanted to find out people who were lost to follow up and to put them back on treatment, and universal viral load testing. So every time a patient comes to check their to get the next package of ART for drugs for their treatment, so that they are tested for the viral load. So once in every 3 months or 6 months, they're testing for the viral load along with the CD4 count, and that is documented. So the program effectively is looking at not only, okay, we are supplying with ART, but we are also looking at how effective is this ART in actually achieving uh, reduction of viral load as well as improvement of CD4 count. So you know that a viral load has to reduce for people to no longer transmit the HIV infection in sexual contact. So one of the main objectives of antiretroviral therapy, other than obviously protecting this patient from going into AIDS, one of the main objectives of highly active antiretroviral therapy is to prevent transmission. And prevention of transmission can only be achieved with adequate viral load suppression. So from February 28 onwards, 2018 onwards, there is universal viral load testing. And during COVID-19, there were various challenges with respect to the program activities. So during this, the initiatives of multi-month dispensation were taken, okay, where patients were simultaneously given treatment for 3 months, 6 months to prevent them from having to repeatedly visit the hospital because HIV patients were already immunocompromised. So them getting infection from COVID-19 would have been dangerous. So those initiatives were taken to ensure proper treatment during the period of COVID-19. Now, looking at the HIV/AIDS Prevention and Control Act of 2017. So this, as I was saying, this is the only act that is specifically there for one particular communicable disease. Okay. The HIV/AIDS Act 2007, it is basically to prevent discrimination against HIV positive people. Okay. To prevent discrimination in terms of employment opportunities, in terms of educational establishments. So they should have the right to read at all educational institutions, irrespective of their HIV status. Healthcare services, so all kinds of healthcare services they should be receiving. Residing or renting property, standing for public or private office if they want to be in the legislative body or anything, and provision of insurance. So you know that HIV positive people, since they are immunosuppressed, they are prone to get various other co-infections, opportunistic infections where they may fall ill. So it is very, very necessary for them to have access to insurance that protects them from catastrophic out-of-pocket expenditures, like high out-of-pocket expenditure that can potentially land them into poverty. Okay. So for that reason, this act has been put in place to ensure that they have equal opportunities to work, to educate, to healthcare service, to rent, to do all kinds of things, and they do not face any kind of discrimination. Moving on to, if we look now, so now we are having the NACP phase 5, which started from 2021 and will go on till 2026. So if we look at where we were at the beginning of the NACP phase 5 in 2021, so the targets, global targets, whatever are there regarding HIV are from the baseline of 2010. Okay. So the global average reduction in new infections has been 31% from the baseline of 2010. But the NACP program has achieved a 48% decline as of before the beginning of NACP phase 5. And AIDS-related mortality also in India declined by 82%. Both of them are greater than the global average. So thereby showing that the NACP was doing a lot of good things. And while the prevalence of HIV in India is also low at 0.22%. Okay. The main thing is that the 2030 goal, so we are committed to the Sustainable Development Goals of 2030. And other than that, one of the goals is to end the AIDS epidemic as a public health threat. Okay. So the targets are a 90-90-90 target where 90%, we have a 90% decline in HIV infections as well as mortality by 2030. And that is proposed to be achieved by that 90% of those who are HIV infected know that they have HIV, that is, they're diagnosed. 90% of those who are diagnosed, they are put on treatment, and 90% of those who are put on treatment achieve adequate viral suppression. Okay, so for that only we are also monitoring the viral load suppression as of now. Okay, so as of before the beginning of NACP 5, we were standing at 78, 83, and 85. So the NACP 5 basically wants to strengthen the program further to ensure that we are achieving not only 90, 90, 90, but going one step ahead and achieving even more. So if you want to look at the burden of HIV in our country, you will see that it is the southern states of India, mostly in Tamil Nadu and in Andhra, Telangana, in Karnataka, Maharashtra, and parts of Tamil Nadu, southern districts of West Bengal, northeastern states, Manipur, Nagaland, and parts of North India, Bihar, and eastern UP, where you have a high prevalence of HIV. So this is district-wise data. So districts in India are classified into high, moderate, low, or very low, depending on the prevalence of HIV among adults. So if the prevalence of HIV is more than 1%, or the population size having, like, people having HIV is more than 5,000, then that's a high burden district. If it is in the range of 2,500 to 5,000 and adult prevalence is 0.4 to 1%, then it's a moderate prevalence district. If prevalence is 0.2 to 0.4% and its burden is 1,000 to 2,500 people, it's low. And if it's less than 1,000 and You have a adult prevalence of less than 0.2%, then it's a low burden district. So that is the classification of districts according to high, moderate, low, and very low. Now moving on to the goals of the NACP 5. So the NACP 5 was launched in 2020-21 and it is to be there up to 2026. So it has 5 goals. The first goal is to reduce annual new HIV infections by 80%. Second goal is to reduce AIDS-related mortalities by 80%. Third goal is to eliminate vertical transmission of HIV and syphilis. So the goal of dual elimination of HIV and syphilis. Now, if we have to achieve this, so that has to be achieved by the goal 4, which wants to promote universal access to quality STI RTI services to at-risk and vulnerable populations. So the syndromic management of STI RTI along with the availability of highly active antiretroviral therapy comes under this goal. And goal 5 is to eliminate all stigma and discrimination associated with HIV/AIDS. Okay, so this is very, very important for you. These 5 goals you must remember. First goal is to reduce all new infections by 80%. Second is to reduce AIDS-related mortalities by 80%. Third is to eliminate vertical transmission of HIV and syphilis. Fourth is to promote universal access to quality STI/RTI services to at-risk and vulnerable populations. And fifth is to eliminate HIV/AIDS related stigma and discrimination. Okay. So going ahead, how to meet this? So these goals and strategies, they were kept with the 2030 mandate in mind, where we have to reduce it by 90% by 2030. So under these goals, some specific objectives are there in NACP phase 5. So the idea is that 95% of people who are most at risk of acquiring HIV infection use comprehensive prevention. Okay, so this is compliance with HIV preventive techniques among 95% of the high risk population. And then 95% of HIV positive people know their status, 95% of those who know their status are on treatment, and 95% of those who are on treatment have achieved suppressed viral load. So if you look at the global targets of 90-90-90, these are the global targets, but the Indian target as far as the NACP phase 5 is concerned is 95-95-95. 95% of infected know their status, that is they're diagnosed. 95% of those who are diagnosed are put on treatment, and 95% of those who are on treatment have achieved suppressed viral load. Okay, so this is about the people who are infected. The first objective is about people who are at risk. So among them, we want 95% compliance with respect to the HIV preventive uh, uh, behaviors that they need to take. Okay, and as far as the infected are concerned, we want 95% to be diagnosed, 95% to be treated, and 95% to achieve viral suppression. Okay, next moving on to prevention of parent to child transmission. So 95% of pregnant and breastfeeding women living with HIV should have suppressed viral load towards elimination of vertical transmission of HIV. So the objective is to achieve a zero vertical transmission of HIV from parent to child. Okay, and that can only be achieved if 95% of pregnant and breastfeeding women living with HIV have suppressed viral suppression. So they have adequate viral suppression. Okay, and less than 10% of people living with HIV and key populations experience stigma and discrimination. So stigma and discrimination, this is in line with the goal 5. The objective 4 is wanting to reduce. So these are all about generally about HIV prevention and control. There are 2 more objectives for STI and RTI, which is a universal access to quality STI RTI services for at-risk and vulnerable populations. So the syndromic management of STI RTI services should be present at all centers, and attainment of elimination of vertical transmission of syphilis. So this is the dual elimination target of syphilis and HIV. So if you look at what are the various services that are to be available at various centers.